Hi, my name's Meg Harrison and I'm the nurse practitioner candidate with Barwon Health with the Community Palliative Care Service. For the case report 2 in the Therapeutic Medication Management Unit, I'll be discussing the medication morphine for its use with dyspnea. To discuss this medication class of morphine, I'll present a recent case. Max is a 78-year-old gentleman with pulmonary fibrosis referred from his respiratory specialist due to his recent functional decline and his advanced disease progression. He's now requiring oxygen 24 hours a day. His disease is also complicated by a bipolar disorder with associated severe anxiety. He's got other symptoms as well, the dry hacking cough that keeps him awake at night, some nausea and some early satiety, that feeling of fullness, and with the associated loss of weight. So I will focus on the pharmacokinetics and the pharmacodynamics of morphine. However, in this particular scenario, I need to as well focus on his bipolar disorder, with there's a complication with the lithium, and in particular as well with benzodiazepines. Lithium has a very narrow therapeutic index, meaning that it's ineffective at one end and then becomes toxic at the other. And this medication the dose needs to be adjusted according to plasma concentrations. Lithium is excreted by the kidneys from the proximal tubules along with sodium, so any changes in his renal function or sodium intake could cause an increase in lithium plasma concentrations. Therefore, renal function alongside with lithium levels need to be monitored regularly. I needed to monitor and educate other nurses for signs of lithium toxicity, such as nausea, vomiting, muscle weakness, polyuria, tremors, confusion, slurred speech and dizziness can also occur due to this accumulation of lithium. We needed to be cautious as well because we'll commence the use of morphine, and he had benzodiazepines, so some of the side effects for lithium toxicity could be increased sedation, and it could be actually related to the other medications, so we just needed to be aware of this. Max had also been on benzodiazepines for a long time, and we know that this can build a dependency and a tolerance, so higher doses may be required for symptomatic benefit. We did trial oxazepam as a BD dose to see if we could wean him off the lorazepam, just so he just had one benzodiazepine. However, it wasn't effective and he needed the lorazepam as breakthrough. And as his psychiatrist said, it is about comfort measured and symptom management. Therefore, it was important to keep those under control. That required 2 benzos. She actually thought that that was fine. So morphine, the pharmacokinetics with morphine. So it's an agonist effect on all opioid receptors as it mimics the action of endogenous enkephalins and endorphins. It acts on the mu receptors, the kappa and the delta. The mu receptors as an analgesic effect, and in higher doses respiratory depression. The kappa is a sedation and that euphoric effect, and the delta causes urinary retention and the side effect of constipation. Not always, but there's complications. In its oral form, it's important to note in its oral form it has a high first pass metabolism. That's meaning that the bioavailability is poor, with approximately only about 30 to 40% of its original dose. It's important to know that it has a high first pass metabolism, especially when converting from an oral morphine to a subcutaneous morphine, because the doses needed to be calculated accordingly. Morphine has 2 active metabolites, morphine 3-glucuride, which causes the unwanted side effects, and morphine 6-glucoconoride, which also has more positive effects. They are both excreted in the kidneys, therefore once again renal function needs to be monitored. Because as you'll find, the build-up of metabolites, when you see someone who's opioid toxic, they get those myoclonic jerks and the sedation that you see in opioid toxicity. The known effects of analgesic as what most people know morphine for, and also for some of the common side effects, so nausea. Then that is because it stimulates the CTZ, so that's the chemoreceptor trigger zone, and also the other main symptoms of constipation, and that's because it decreases GI motility. The medication Maxilin or metoclopramide can be used as an antiemetic and also as a prokinetic, so it can empty the stomach because he also had early satiety as well as nausea. We'd also need to focus on aperients and what aperients he's on, especially when we looked at increasing his oral quick release morphine, the Ordine, to a slow release. So I needed to implement some Movicol alongside his coloxamine Senna. It is also important to mention, and especially for Max, that opioids, especially morphine, has an antitussive effect. And Max had a really irritable, dry cough at night, and when we started using the Ordine, he had a really positive effect. And it enabled him to have better night's sleep. So that was one thing that we found in Max's case, the morphine was really effective. Morphine also has a histamine that can cause an itch, but Max did not have this side effect. Or did he show any signs of respiratory depression or sedation, even with being on 2 benzos and the opioid. So there is lots of evidence and clinical trials and articles for the use of opioids with refractory breathlessness. There was a Cochrane review done in 2002. Caro et al., Viola et al. Have all done many systematic reviews and meta-analysis to all endorse the use of opioids in the setting of refractory breathlessness. And in particular, Booth et al. Also stated in her study that patients with interstitial lung disease often have stimulation of the respiratory centre and may benefit from the use of opioids. Some of the barriers that we find is the perception from patients and health professionals. A lot of patients associate morphine with dying, and therefore it's really important to educate them what palliative care is about and what morphine is about. And it's about improving their quality of life and their function in their deteriorating condition. And it's really about symptom management. For health professionals, I think I always remember as a student nurse, an 80-year-old lady with a fractured knob given IV me, who was completely opioid naive, and she went into respiratory depression and had a respiratory rate of about 6. But that was in the scenario of an elderly lady, very not much weight on her, and was given an IV, where in Max's scenario and most of our other patient scenarios, we use low-dose oral morphine. So we commence it at 1 or 2.5 milligrams. See there. So morphine acts on the central nervous system and centrally on the brain. And a study done by von Leopold in 2008 looked at where dyspnea is perceived in the brain and found it to be perceived in the central area, exactly where pain is perceived as well. It's that unpleasantness of breathing that they found. As we discussed, we already know morphine has an analgesic and euphoric effect, and the theory is also that it alters the perception of the breathlessness. Therefore, Max found that he was able to do more physically and didn't feel dyspneic. It didn't actually alter his respiratory rate or anything like that, or his being hypoxic, but it made him feel better. Initially, he commenced on Ordine just prior to exertion, and we started it at night as an antitussive, and it was really effective. He then started using it more regularly prior to exertion and things. And then we found, as Ordine only has a half-life of 4 hours, that he needed to start on the slow release. So it gave him the half-life of 12 hours, and it gave him a steady state of plasma concentration of them, and gave him better symptom control. It also allowed Max to use the Ordine as a breakthrough for additional times where he was severely dyspneic. It's also important not to just discuss the morphine in Max's case, but it's also because he had another diagnosis of bipolar. He hadn't had any manic episodes or severe depression, and his mood was actually quite stable considering the fact that his prognosis was poor and he's had a deteriorating condition. He was still quite jovial and enjoyed some of the things that he still enjoyed in life, listening to music and things, and was actually had adapted quite well to his deterioration condition. However, whenever he was breathless, that would cause huge anxiety. So we used a non-pharmacological approach with the changing in position and relaxation and a fan and things like that. And initially in the combination with Ordine, it was really effective. However, when he was extremely anxious, we needed to combine the benzodiazepines as well as a breakthrough anxiolytic for him. With other patients, we would need to be a lot more cautious, but Max had used anxiolytics, benzodiazepines for many years. So in his case, he didn't have as many of the sedation side effects. My role as a nurse practitioner is also to plan ahead and to prepare Max and his wife for where he wants to be cared for. So we have to discuss those goals of care. He really did not, he had an advanced care plan. He did not want CPR or intubation, and those things were very obvious when we first met him. He was a very pragmatic man. However, he also never wanted to return to hospital, even in an infective exacerbation where IV antibiotics could be appropriate. He didn't want any of these. He didn't want any of his life prolonged at all. And he was very clear that he wanted to die at home. So to be able to achieve this, I really needed to monitor his condition for potential side effects that, could potentially cause him to go back into hospital. So say if he got a lithium toxicity or an opioid toxicity, I need to monitor those things to avoid him going back to hospital because his wish was to be at home. So I needed to regularly monitor his lithium levels and his renal function. And needed to also consider when it would be appropriate to wean the lithium off when his condition was deteriorating, and also for when he couldn't swallow his tablets anymore. I discussed this with his psychologist, and something like olanzapine, which is an antipsychotic, comes in a wafer form and could be very beneficial for Max. I'd also need to think about when he was unable to swallow and his condition deteriorating, the use of morphine as subcut, especially as I said before, we'd have to give about the third of the oral dose. So say Max was having about 30 milligrams of oral morphine, he'd only require about 10 milligrams of the subcut equivalent. And also the dose of midazolam we would usually use in the subcut infusion, but I would really need to discuss it with the palliative care consultant, considering he was already on 2 benzodiazepines, and I'd need to get their opinion and their advice as to what type of dose I'd use in this scenario. His goals of care would be for comfort and symptom management, and it would also be about supporting his wife at home so we could